So I have a question here, and I'm going to actually combine two questions that came through. One of the questions had to do with the use of long-acting opioids as opposed to short-acting opioids. So for example, use a long-acting opioid on a consistent basis to so-called manage pain, rather than waiting till pain catches you and then trying to chase it with a short-acting opioid. And the other question that I'd like to sort of string into that is the use of methadone for chronic pain. So not methadone maintenance therapy for addiction, but methadone for chronic pain. And how does it compare to other sustained release opioids that you might use? And is there a difference in the risk of addiction or dose escalation with methadone compared to other opioids? That's a straightforward question. Let's start with long-acting versus short-acting opioids.
Yeah, so long-acting, short-acting. So the short-acting opioids, the action starts very quickly. So you take the pill, and within 20, 30 minutes, you start seeing the effects, and they last between 2, 3, sometimes 4 hours, and that's gone. The long-acting opioids, it takes longer for the person to start feeling the effects, but they last 12 hours. Most of them last 12 hours. Some last a little bit less, and there are now long-acting opioids in Canada that last 24 hours. So what happens is, if the short-acting opioids usually are the patients use when they have, the pain is increasing, they did some activity, let's say that they went to the physiotherapy, they come back, and now they're in pain. So they take the short-acting, wait 20, 30 minutes, and then start having the effect. By about 1 hour, the effect is maximum, and then they start seeing the effect. So then the pain during the day is like this. I don't have pain, then I do something, my pain is up. And then they take the short-acting, my pain goes down. And then I do something, my pain goes up, and then I take the short-acting. And then so it goes like this the whole day. So, and then when a person is taking many short-acting throughout the day, we say it's time to convert to a long-acting. So that's what we do. We calculate how many short-actings they're having during the day. We calculate, and then we say, now you're going to take every 12 hours. It's not like an antibiotic that you have to take every 12 hours. You take twice a day, and then it's going to maintain the concentration in your blood, and so it prevents the pain from coming. But they still have some periods, so it's like this. Your life is more predictable. You can, you know that your pain is going to be more stable, and you don't need to be chasing after the relief of pain. But then they say, I still have some periods of time that I do more, and I have that period of time that I have more pain, so then they take another short-acting and the pain goes down. That's usually how we explain to patients. Some patients, and I know some physicians, they tend to maintain their opioids only on long-acting, usually because it's, when you get to high doses of long-acting, what is just 5 milligrams in an ocean is like putting some drops of salt in an ocean. You know, what is 5 milligrams if you're taking 400 a day? It's almost nothing. It's more psychologically beneficial because the patient says, oh, I'm having pain, and then it's more psychological. They take the tablet, magical tablet of 5 milligrams, but they forget that their system is already loaded with 200, 400, 500, so it's almost nothing. So then it's preferable just to stay on the long-acting opioids, and if the pain, they still have some periods of time that the pain is above that threshold, they can do some relaxation, some meditation, some exercise, some stretching, go for a walk instead of taking the pill. The other thing that also happens is, and this is again with higher doses, is that it's what we call end-of-dose withdrawal symptoms. If the patient is taking the medication every 12 hours, by the 8-9 hour, they are having withdrawal, which is the abstinence symptoms from that dose, because that dose was so high. By the 10th hour, the medication is slowing, and it's not the pain that is getting worse, but they're getting the withdrawal symptoms, which is they're very unpleasant. They get agitated. The withdrawal symptoms are agitation. They get chills, they can get a stuffed nose. It's like a bad cold that you're having and you don't know how to explain. And sometimes the patients don't know exactly the difference, or nobody ever explained to them what are withdrawal symptoms. I know a lot of patients, nobody ever explained that they what are the withdrawal symptoms. So they feel that they express themselves as having pain, but that's because of the high dose that they received 8 hours ago is starting to get down. So that also explains the ups and downs.
And I'll just add to that when we're talking about patients with pain who may be at increased risk of abuse or addiction because of past history of other substance use or for whatever reason, that's where it might be a good option to avoid the short-acting, the immediate release products, because again, that sort of gives you sort of more of an immediate boost that has a higher abuse liability or addiction risk associated with it. So avoiding that if possible as one of those measures of trying to maintain more control and having sort of a modified therapy for people with increased risk.
So where does methadone fit into the chronic pain management business? For pain management, not for addiction.
Well, exactly. Well, and I'm more familiar with it from the addiction side of it, but methadone can be used for chronic pain as well. It has additional sort of mechanism of action in addition to its sort of opioid effects. It has some other effects in the brain that can be beneficial for certain types of pain, and so it is a good option. It's a sort of a long-acting opioid, but unlike in methadone maintenance treatment where it's a once-a-day treatment, for pain it needs to be dosed more frequently, often 3 times a day, for example. But it does have a sort of a long duration of effect. It can be quite beneficial for pain, but just to mention that's why it's also a good option for people who have pain and addiction, because it can help in some people manage both, where it can be helpful for the pain and help with their opioid dependence. You guys might want to add more on the pain side with methadone.
No, I think it's a fair comment. I mean, I found methadone very useful for certain types of pain, particularly neuropathic pain from nerve injuries. I've had some excellent results with patients with diabetic neuropathies, where the methadone seems to provide a better sort of analgesia than other opioids in combination with their other medications. It is a long-lasting drug. All of the other so-called long-acting drugs are mechanically formulated, sustained release preparations of short-acting drugs. So OxyContin is still oxycodone, which is a drug that once it's in your system has a duration of action of about 3 or 4 hours, but it's mechanically built to slowly release over time, as is MS-Contin, Cadian, Meslon. All of these things are short-acting drugs with sustained delivery systems, and so it depends on how the delivery system works for you. And the fentanyl patch, of course, fentanyl has also a 3 or 4 hour duration of action, or 3 or 4 hour half-life for elimination, but it's a patch which slowly releases over 2 to 3 days through your skin, depending on how active you are and so on.